Hello, my name is Harish Venkatraj, and I'm a second year resident at Mercy Hospital, Chicago. Now, I have a poster where we describe a case of hypertriglyceridemia induced acute pancreatitis. Pancreatitis can be triggered by many factors, with one rare etiology being hypertriglyceridemia, and this condition is spiking in incidence with the sedentary lifestyle and increasing obesity in our general population. The duration of this hypertriglyceridemia and the levels at which it peaks usually corresponds to the severity of the pancreatitis, and a triglyceride level greater than 2000 usually indicates that a patient has a genetic component as well added on top of the secondary cause which triggered it to begin with. Here I present one case of hypertriglyceridemia induced acute pancreatitis, which was successfully treated with intensive insulin management through IV and fluid resuscitation in the ICU. This was a 34-year-old man with insulin dependent diabetes mellitus type 2 and hypertriglyceridemia. He came in with symptoms and signs of acute pancreatitis. So his lab work showed a sodium of 123 millimoles per liter, a lipase of 1883 units per liter, and triglycerides of 7171 milligrams per deciliter. And we did a CT which confirmed acute pancreatitis as shown in the CT image below. So he was brought to the intensive care unit and he was started on an insulin drip and D5-LR with a blood glucose goal of 140 to 180 milligrams per deciliter, and we kept checking the triglyceride levels every 12 hours. With this therapy, the triglyceride levels decreased by more than 60% in the first 24 hours, and at that point, once the triglyceride levels started going down, the pseudohyponatremia also started creeping up. The sodium levels actually started going up as well, which is evident by the two graphs shown below this pancreatic image. IV insulin was transitioned to subcutaneous insulin once the triglyceride levels were less than 500. At that point, we resumed this diet as well, and we added oral fenofibrates and high-intensity statins, such as rosuvastatin in this case. Acute pancreatitis is diagnosed with acute abdominal pain and tenderness with significant elevation of pancreatic enzymes or an abnormal imaging. The Apache 2 score of greater than or equal to 8 or a Ranson score of greater than 2 makes it a severe pancreatitis. Hypertriglyceridemia could be familial or can occur secondary to uncontrolled diabetes mellitus, obesity, alcohol consumption, or estrogen therapy. The hydrolysis of triglycerides by pancreatic lipase promotes the accumulation of free fatty acids, which plugs the pancreatic capillaries, resulting in ischemia and acidosis, and at that pH, it activates the trypsinogen, followed by an inflammatory cascade. IV insulin stimulates and activates lipoprotein lipase, which degrades chylomicrons and thus reduces triglyceride levels. Plasmapheresis is an alternative approach in the management of such a case. However, the cost and availability of this modality is a limiting factor, and its superiority over IV insulin is not well established. Therefore, along with lifestyle modification and fibrates for long-term management, we recommend the treatment of hypertriglyceridemia-induced pancreatitis with intravenous insulin for rapid reduction of triglyceride levels in order to decrease hospital stay and reduce the morbidity and mortality associated with pancreatitis. Thank you.